Tengan ustedes muy buenas tardes. Bienvenidos a un nuevo encuentro webinar de la Sociedad Argentina de Infectología, en un horario desacostumbrado a el que venimos manteniendo semana a semana, pero con una explicación que tiene que ver con el título de la charla del día de hoy. Vamos a estar hablando con profesionales de Australia. Y es por eso que, para que podamos tener un intercambio en vivo con ellos, tuvimos que adaptarnos a este horario que representa, como ustedes imaginan, la mañana ya del día sábado allí en el otro continente. Quiero invitar al doctor Omar en principio, para que se sume a esta sala. Allí están Omar, buenas tardes. Allí están Nick, Allen y Craig. Vamos a tenerlos allí en espera. Y vamos a contarles, Omar, a nuestros espectadores que tuvimos un trabajo de producción arduo porque grabamos previamente la exposición de los colegas, lo tradujimos al castellano para poder ofrecerles a ustedes en 2 videos una presentación más amena. ¿Cómo te va, Omar? Buenas tardes.
¿Qué tal? Buenas tardes a todos. Muchas gracias a todos los que están conectados para ver la presentación. Esto es gracias a un esfuerzo de Nick Walsh, que es un amigo de la época en la que trabajaba en OPS. Muchas gracias, Nick, por estar. Y tenemos el placer de tener al presidente de la Sociedad Australiana de Infectología, que es Allen, y Craig, que está trabajando con testeo de contact tracing, o sea, o búsqueda de contactos, y con un sistema de seguimiento y traqueo de enfermedades respiratorias, de flu tracking. Así que creo que van a ser 2 presentaciones muy interesantes, muy cortitas, y a partir de ahí un poco de paciencia, porque las respuestas y la sesión de respuestas, preguntas y respuestas va a ser obviamente con mis limitadas capacidades de traducción del inglés al español. Así que esperamos que tengan preguntas, y sin más pérdida de tiempo vamos para adelante. Después vamos a saludar y hacer la introducción de Nick y Allen para no perder tiempo. Así que vamos con los primeros videos ahora mismo.
¿Cómo no? Vamos a compartir primero entonces el video del doctor Allen Cheng. Él es médico de enfermedades infecciosas en el Hospital Alfred Health y epidemiólogo en la Universidad Monash en Melbourne, Australia. Actualmente es, como bien dijo Omar, presidente de la Sociedad Australiana de Enfermedades Infecciosas. Está además involucrado en varios comités consultivos del gobierno, incluido el Comité Principal de Protección de la Salud de Australia, que asesora la respuesta precisamente del gobierno frente a la pandemia de COVID.
Okay. So thank you very much for the opportunity to present and share some of the lessons that we've learned in Australia from COVID-19. So I'm infectious diseases physician. I think I'm the equivalent of Omar in Argentina. I'm the president of our Australasian Society of Infectious Diseases, which is for infectious diseases physicians. And also sitting on our Australian Health Protection Principal Committee, and I'll explain a bit more about that and some of the other roles in a moment. So Australia is actually about as long as Argentina, and but 3 times as big, with a population about half that of Argentina. And obviously, when we think about COVID-19, we have a number of advantages. We are basically a very large island with no borders, land borders with other countries. Although we have quite a relatively small population, it is quite highly urbanized. So most people live in cities, and very few people live outside of the major cities. We are a high-income country and have a universal healthcare system, a public healthcare system, with some private hospitals as well. Our reference laboratories are relatively strong, although there are some issues with having multiple diagnostic laboratories. And it'd be fair to say we have a relatively strong public health system, particularly in Hunter, New England, where my colleague Craig Dalton is from, but it does vary around the country. We also had quite a lot of early warning that we were going to have problems. Our first case of COVID-19 was on January the 25th, and we had a small number of cases in travellers towards late January and early February. We do have some disadvantages, though. Two of our cities are in the top 20 destinations for Chinese travellers, it's Melbourne and Sydney. Australia is not really a single country. It has 8 different governments. Some of the jurisdictions, Tasmania is very small, Victorian, New South Wales are very large, and they have different capacities to cope with health crises. We have quite a diverse population with many languages and cultures, so things cannot always be messaged in English or in a single language, and we need to communicate in many languages. There's always been an awareness that we have many remote Aboriginal communities, and these are places that are very many kilometres from major centres, and Aboriginal and Torres Strait Islanders, our Indigenous communities, have a high rate of chronic disease and are very vulnerable to infections. We have, like everywhere else in the world, an increasingly casualised workforce, which can make it difficult for example, leave arrangements. And our diagnostic laboratories, there's many private laboratories, and they're somewhat fragmented. It's hard to communicate with some of these laboratories. So I mentioned before about our system of government being relatively complicated, and this is reflected in some of the arrangements for public health. So at the moment we have what's called a national cabinet, and the national cabinet is comprised of the Prime Minister of Australia, and then each of the state and territory premiers, which are, I think, the equivalent of governors in Argentina. And so they meet every week or 2 weeks to make decisions about national policy. And then advising them is what's called the Australian Health Protection Principal Committee, which is made of the chief medical officer of the country, and then all the chief health officers of each state and territory. So this is mostly public health officials, bureaucrats, and there's a number of people like myself and mathematical modelers and infectious diseases physicians who are invited experts to this. So this sounds a little bit like your presidential advisory committee. And then below them are a number of different committees. One of these is what's called the Communicable Diseases Network of Australia, which is all the heads of the communicable disease branches. We don't have a Centre for Disease Control, and so this is our arrangement, is to have lots of committees, and it's very much a network-based issue. Very early on, we had what's called a National Incident Response called, and a National COVID-19 Response Plan was rapidly adapted from our influenza response plan. This is our epidemic curve in Australia, and across the bottom you can see some of the measures that were taken. So you can see we put on a travel ban for passengers coming from China, and then as further countries had epidemics, the borders were closed to those countries, and then by mid-March completely closed. And then you can see some of the other measures that were taken towards early to mid-March. At that time, a lot of the cases that were coming in were actually travellers rather than local transmission. But I think there was sort of a lot of enthusiasm for closing a lot of things in Australia, and you can see some of those things there. So at one point, gatherings were only limited to 2 people. You could only meet one other person that was not in your household. I think it's quite interesting to see that the settings that we've had major transmission events in are really the same settings that almost every other country has seemed to have in the world. So obviously cruise ships, there were many Australians on the Diamond Princess, but we had another cruise ship that docked in New South Wales and had many cases there. We haven't had many outbreaks in schools or childcare centres, but there was one notable one in New South Wales. nursing homes or aged care residential facilities. There's been a number of outbreaks in those. Meatworks, I think, require a lot of people to work very closely to each other, and we've had an outbreak of that. And then more recently, we've had some problems with quarantine facilities where overseas people are being diagnosed with cases and they've continued to transmit on to some of the security guards in those areas. And then we've had a number of quite large outbreaks that have occurred at family occasions, particularly in Victoria and last also. So after the cases started to settle down, the Prime Minister announced that these were the conditions that we needed to have before we could reopen again. And this was announced on the 16th of April, and we've basically been spending the last couple of months working on all of these. And these were the conditions were to have a surveillance plan so that we had good situational awareness of where we were and what we needed to be doing, and with a lot of mathematical modelling and analysis behind that. We had to have more public health capacity, and there was a COVID-safe app that was launched, which hasn't been that successful. And then we had to have an assurance that our health system could cope, the hospitals and primary care could cope with what would come, and that included supply lines for personal protective equipment and pathology and ventilators and so on. So in the last couple of weeks, most states have not had many cases. So a lot of these cases in other states other than Victoria have actually been in travellers rather than in the community. But you can see in blue, we've had this ongoing trickle of cases in Victoria, and over the last couple of days, actually, that has increased to about sort of 20 to 30 cases a day. And these are arising in certain parts of the city. So these are being called hotspots in these 6 areas. The grey is the city of Melbourne, and then the orange are these hotspots. So they're quite large areas, and they're sort of on the outskirts of the city. And so the response to this has been to deploy mobile clinics. The army actually have been sent in, and a lot of hospital workers have been sent out to some of these areas to go knock on doors and make sure that people get tested if they're unwell. There have been clinics that have been set up in shopping centres so that people can easily get tested. And some of these outbreaks have occurred in ethnic communities, in many communities that where English is not their first language, and there is a lot of engagement with some of these community leaders to try and make sure that the messages get through. The Premier has also announced what's called pandemic leave for some workers who cannot take time off work. They don't have any sick leave from their work. They can get a payment from the government to make sure that if they quarantine, they can still support their families. These outbreaks have been relatively complicated. I mentioned the quarantine hotels. Some of them have involved quite large households. So there are 20 or 15 or 20 people in a household, and at family gatherings. And then again, involving some of these smaller communities. Some of the ongoing issues that's been discussed in Australia are we actually aiming just to suppress the virus, or are we trying to eliminate it from the country, bearing in mind that there is a risk of introduction. We still have internal border controls, so that between some states, such as between New South Wales and Queensland, and I think South Australia and Western Australia, there is still, you cannot travel across the border, or you have to quarantine if you do travel across. And then how long can we continue to quarantine incoming travellers for? Obviously, it's a big undertaking to do that. I think the point of that looking for marginalised populations, I think we have, Singapore had their issues with foreign worker dormitories, and I think we have now had these issues with our marginalised populations as well. I think it'd be fair to say that public health capacity is still a little bit limited. It's one thing to have lots of contact traces, but particularly in complex outbreaks involving, businesses or hospitals or nursing homes, this is not something that that can be left to routine follow-up. So in Victoria, there was about 60 of the public health officers, and then they brought on a whole lot of nurses. Some of them were nurses that would normally do elective surgery. Some of them were people that happened to be in Australia on holiday. They were nurses from Ireland and England, and that otherwise would be backpackers in the country. And they were very helpful at some of the routine follow-up. But when it got to very complicated situations that required judgment, it becomes somewhat more difficult. And then I think the other issues that most countries have had, personal protective equipment supply is still somewhat limited in Australia, even despite not having so many cases. And then obviously the economic impact and the political considerations around that as well. So in thinking of sort of what can be done, I think this is the public health toolbox. So things that the messaging that we put out to people about physical distancing and personal hygiene and so on. There's the actions that rely on knowing that a person is a case. So this is the sort of traditional test, trace, and isolate, and then more complex outbreak management, and then closures of school or work. There's the actions that are reliant on regulating behaviour somehow, and obviously this does require perhaps some enforcement, so stay-at-home orders and limits on gathering and capacity, and obviously it's very hard to police some of these things. And then obviously the border measures. And I think Craig has discussed contact tracing. So in Victoria, which is a state of 6.6 million people, there's probably about 60 public health officers normally, and then about 1,000 contact tracers overall. And then I think there is a consciousness to try and separate out some of the tasks. That the first part of it is to investigate the case and find out who their contacts are. The second task is to find those contacts and to make sure that they're in quarantine. And actually, even after you put them in quarantine, there is a need for ongoing support to make sure that their pets are looked after and they have food, and they can stay in quarantine to keep them there. So I think the response to increasing cases, at least in Australia, is to try and sort of take assessment of what is the current situation, not just the numbers of people that are being diagnosed, but what is the capacity of the health system and of the public health system to respond to that, and to try and get an idea of what is the behaviour of the population, what are people doing. And so we're looking at data such as Google Analytics and smartphone movements, just from Google and Apple, to see what sort of people are moving. We're doing surveys to try and ask them, how have you returned to what you normally do, or are you still able to stay away from other people? Then the other marker, I think we use this quite early on as well, is to ask ourselves, is there enough testing going on? So some of the markers for this are the case fatality. Obviously, that's very heavily influenced by age, but that gives an idea of how many cases might be missed. And also the proportion positive. If that spikes up above 5%, then maybe there's not quite enough testing and there may be missed cases again. And then it's not just the numbers of testing, but also who is being tested, and are there populations that are being missed? And obviously we have missed some in Australia as well. And then if there are people that are not tested, what are the things that will allow them to get tested, or what are the barriers to stop them getting tested, and if those can be addressed. And then in terms of keeping an eye on the contact tracing system, how many contacts are there for each case as a marker of social distancing and so on. what is the delay in completing the contact tracing? How long does it take to get to the end of that? And then how many of the contacts that are nominated are actually can be located. I think this has been a question that we have asked about when when do you need to close and when might you need to open? And I think this was early in our outbreak. The decision to close was the realization that just contact tracing or just public health probably couldn't control it, the outbreak by itself. So where the number of cases exceeds the capacity of health services or public health to treat them or to prevent them is probably an indication that a lockdown is required. And noting that there is a delay in response. So even this recent number of cases in Victoria, we don't expect that all the things that we do now will probably take effect for probably another couple of weeks. And in terms of opening, I think the idea is to try and control the virus by less disruptive measures, and then having all these indicators in place to know when do you have capacity to do this is important. In terms of different epidemiologies, this is obviously an issue that we're facing in Australia with active cases in Victoria, but not active cases elsewhere in Australia. And I think there is this argument in Australia that some people, particularly people that live close to the border, will say, well, why can't I go over there? And particularly with internal land borders, it's very difficult to enforce to stop movement across borders. So I think at a jurisdictional level, at a state and territory level, the argument is made that if we don't have any cases and they have cases, we can open up further because we're not letting in their infection from over there. When we get to sub-jurisdictional borders, so suburbs of Melbourne, it is almost impossible to enforce. You can't lock down a particular part of a city because there are just so many ways in and out of them. And so that probably isn't feasible, and we're relying on people, recommendations and messaging to these areas to try and reduce the traffic. In terms of, I think this argument is made that, there is the need to protect public health is somehow at odds with the impact on the economy. But I think this ignores the fact that uncontrolled infection has probably a large economic impact as well. I'm sure the United States and Brazil will have a large economic impact even despite being relatively open. But I think we do need to recognise that public health measures, particularly those that impact on the economy and on the jobs, have a large risk of making inequality worse. It's easy for office workers to work from home, but it's not so easy for many other groups to work from home. And this is very much a disease that will find the vulnerable populations, as we're finding out in Victoria at the moment. I was also thinking through just what were the sort of, what are the lowest cost interventions that can be done, and I think this is one way of perhaps mitigating some of the impacts of COVID while trying to allow things to activities to happen. So obviously messaging is easy and cheap, but what are the things that can move outside? So can restaurants be outside? Can all the other activities be outside as much as possible to reduce that risk? And then this argument, particularly at very intense transmission, having a universal mask or face shield policy, particularly where social distancing may not be possible, may also be another thing that can be done. So in summary, I think Australia and many other countries have shown that control is possible. This is a disease of super spreading events, particularly in households. So this time, space, people, place, I'm not sure what the equivalent in Spanish would be, is just, sort of define the settings where transmission can occur. the public health toolbox isn't very large, but public communication, contact tracing, things that require regulation and border controls are part of that toolbox. But it is very important to have awareness of where the situation is and to keep an eye on case counts and what's changing. And then there is this need for, in Australia, we call it the Pandemic Intelligence Plan. So this is the surveillance plan, but it's more than just disease surveillance, what we really usually think of surveillance, but surveillance of capacity of the health system and public health, and things like public attitudes and behaviour. So thank you very much for the opportunity to talk, and happy to take any questions.
Okay, so I'm going to present on two aspects today. So national influenza-like illness surveillance, flu tracking, which is a system I coordinate in Australia, and then just a very short snapshot of contact tracing resource requirements in our county of Hunter New England Health. So flu tracking is an online influenza-like illness surveillance system that currently runs across Australia, New Zealand, and it's expanding into Asia and the Pacific over the next couple of years. And basically, we collect symptoms on influenza-like illness and influenza vaccination status. At least that's what we've done prior to COVID-19. And I'll explain how we've adapted for COVID-19 this year. So this is a typical screen that we get with flu tracking. People do it on their telephone or on the web. So it's not an app, it's actually a web page, but it looks a bit like an app. So people just asked about the fever and cough they've had in the last week and whether they've had a flu vaccination or not. And if they answer no to this, that's it. That's the end of the survey. It can be done in 7 seconds. When they join, it takes about 30 seconds to join. They ask about the year and month of born, that they're born, their gender, ethnicity, Torres Strait Islander status, highest level of education, working face-to-face with patients, their postcode of residence, and again, whether they had the flu shot in the prior year of joining. And then after they've answered, if they answer yes, they've had cough and fever, then we ask them about hospital visitation, general practice, or any other advice they've received, the diagnosis given, and were they tested for flu. This has been particularly useful during the pandemic. And then we ask them about a result they get. And we ask them about the result every week for about 5 weeks if they say they've had a flu test, so that we can catch up when they get the test result. And we also ask them about how many days off they've had from normal duties to get an indication of severity of illness. So the survey, I should just tell you that there's about 150,000 people doing the survey across Australia and New Zealand every week at the moment. And we recruit people from all manner of ways. We began with recruiting people in health services, using email to recruit doctors, nurses, allied health. And then we also did media releases. So people are invited through newspapers, television. We have a Facebook site, and we also ask our current participants to invite their friends, family, and work colleagues. So that leads to perhaps 5,000 or 10,000 extra people every year. And of course, during the pandemic, there's been many more join. So the timeline of the weekly survey, it goes out on a Monday morning, probably about 60,000 emails are sent. And we ask about this immediate week beforehand, the Monday to Sunday, asking about what's happened during this week. And we get about 50,000 responses in the first 24 hours, so it's very quick. You can see the survey goes out about 1 in the morning, and you can see about 550 people answer between 1 and 2 a.m. And it really peaked between 8 a.m. and 9 a.m. And you can see 12,000 people responded just this Monday morning at that time. And we get a very, very rapid response from the group. So it has grown every year since 2006, and we get a big bump in our pandemic year of 2009, and another really big bump between 18 and 19. Last year, we had about 43,000 responses per week, and about 80% of participants complete 90% of the weekly surveys. So it's short, so we get a cohort effect. We have a lot of people who are answering every week and from year to year. And this year, there's over 70,000 surveys per week in 2020, and about another 60,000 in New Zealand. So in 2020, because of COVID-19, we added some extra questions: rhinorrhea, shortness of breath, anosmia, change in taste or smell, and COVID-19 testing, whether they've had the test. Yeah, so actual questions, of course, in the survey are runny nose and change in taste or smell. So I'll go through this slowly, but this shows both some past results and our current results. Looking here first at the blue line, this is the cough and fever rate, percent with cough and fever for 2019. And you can see we started in early April. It drops a little, and then throughout May, June, and July, it was up around the 2.5% of participants reporting fever and cough. And again, a little later peak here in late August. And that was a very long flu season. 2019 was a very long flu season. We had this earlier peak, and then it really stayed with us with this kind of summer flu effect that went right through autumn, through fall, into winter. In the black, you see our typical 5-year average rate of flu, fever and cough. And you can see it typically starts rising in mid-July, peaks in August, September, and then drops down again. So that's our typical winter peak here. So this year, of course, and Alan, I think, has explained the actions taken in Australia to reduce transmission of COVID-19, which of course affected transmission of viral respiratory disease in general. And the social distance, physical distance measures were progressively implemented around about mid to late March. However, back in February, the borders were closed. And there's evidence from some studies that our influenza is very much dependent, and probably rightly so, of course, with importation among travellers or contacts of travellers from the Northern Hemisphere. So we probably had some suppression of activity all the way back in February due to closure of our borders to people from China and progressively from other countries, and then restricting really just to returned Australian residents throughout March. So, and I guess the strongest closures occurred around the end of March in terms of not allowing people to gather more than 2 people at a time outside, no visitors to the house apart from 2 people, and closure of most pubs and restaurants. So you can see that our flu tracking cough and fever rates dropped dramatically low down to about 0.2%. where it previously been around 1.5%. So that is, it's only less than a sixth of what we had seen. If we had guessed, we might have thought physical distancing could maybe drop it to half around here, but we had no idea it could drop this low. From late May and mid-June, there's certainly been increasing mixing, relaxation of a lot of restrictions. People are allowed to go back to pubs and clubs. Now we can have up to 20 people visit a house, which is quite a lot. And pubs and clubs have up to 50 people in them in our most populous state. You can see here that we're certainly getting an increase. And this is reflected particularly in our children 0 to 5 and 6 to 17 years of age, increasing much higher. If we look at this here is our COVID-19 laboratory reports. read off this axis, and you can see that basically flu tracking began dropping about 2 weeks before COVID-19 peaked. And we're seeing our increase here in flu-like illness. And this is flu-like illness. It really isn't influenza. We don't think so much. It's like the coronavirus, the rhinoviruses. Our flu data is still very, very low. Not seeing much at all. And I haven't actually added a little bit here, but this is just starting to lift a little. We're getting a little bit more COVID-19, particularly in our southern states, and particularly among some large family gatherings that are spreading, which should be coming out of control, but it's a sign that this may be increasing again. So we wait to see whether flu tracking gives us an early warning. It certainly obviously shows respiratory virus transmission, and whether it's going to give us a good indication of subsequent rises in COVID-19, we'll see, and control. So we also, of course, collect testing, and the testing information has been very good. In Australia, we think we get most of the people with COVID-19, but I think this data suggests we probably miss a lot. So if we look at just people with cough and fever who get cough and fever, about 50% end up getting tested for COVID-19. For those with mild respiratory symptoms, say just a cough, just a runny nose, just a sore throat, it's about 10 to 15%. So it averages around 8 to 10 and 15% during a blitz. So obviously, we're not getting all of the cases of, we're not going to pick up all the COVID-19 cases, particularly the mild ones. And so when it resurges, we will likely miss most cases. And that emphasizes the importance of continued physical distancing and minimizing large gatherings, because we can't hope to capture all cases. So just in summary, flu tracking provides an unbiased estimate of influenza-like illness and perhaps COVID-like illness in the community. It's been really useful during the past pandemic when our laboratory data changed dramatically. And people started testing more. We thought that the influenza rates were much higher than they actually were during the first pandemic because of all the extra testing, but the flu rates in flu tracking showed it was a fairly average year, but with more severe illness. And it also helps us really understand the community testing rates as well. And it's a very easy program to implement. It was implemented in New Zealand in 2018, and they now have more than 70,000 responses per week in the country of 5 million. So I thought I would now just move to contact tracing resource requirements and our experience of that. So I work in a small, well, I guess it looks large on this, but it's a county of 1 million people in southeastern New South Wales. It's a mixture of metropolitan and quite rural areas. And we're responsible for contact tracing for the 1 million people in that area. And we've been lucky to have a lot of support. We might have only had 10 people contact tracing normally, but we've surged through the local health district and have many more. And I would say that we have not been overwhelmed yet, but then we've had low cases, and with a high case count, we probably could not contact trace effectively. And so we surged to about 50 contact traces for our population at the peak back in March. And we thought this might be of interest. We've done a lot of analysis of how many people it takes to trace contacts. And in the early part of the pandemic, in March, we'd say this was easy. It didn't feel easy, but most cases were imported and were easy to identify. We kind of knew that they were coming off ships and planes. They were told to stay at home. They had limited contacts, and it was fairly easy in terms of identifying their contacts and contact trace. So basically, our team calls them, goes through all of their contacts. If they're off a ship, we don't really need to know their source. We know that being on the ship was their likely source. or if they came from America, we knew that was their likely source. So we weren't doing so much upstream looking and questioning or testing. So we found that in an 8-hour shift, a team of 10 contact tracers could contact about 6 cases and their contacts. But now, in our next phase, with many unknown source cases, if it's just community transmission, we'll be looking for their upstream sources and doing upstream testing. And we think, based on our early experience, that this will mean that a 8-hour shift with 10 contact tracers will be able to contact trace about 3 cases and their contacts. So that's quite an increase in resources. So you can imagine if we had to do 30 cases in a day, we would need 100 contact tracers, and that would probably means that we could probably comfortably contact trace about 15 in our county of a million people. Any more than that, we would have to probably decrease our focus on going upstream and just focus on getting people into isolation rapidly and getting that message out, or push some cases over to the next day, presuming that it was just a single daily peak. So I hope that's of use to you. There is data from the US that suggests that they want about 300 contact traces per million people for a county of our size. Unclear what that is based upon. I guess it's based upon having a higher surge than what we have. I might just, the other thing to say is these would be the 10 contact tracers that would be on the telephones talking directly to the cases and their contacts. It doesn't include all the planning people that support them, analyzing the data, working out the workflows. That's probably another 50 people to do that. So I'll stop there and say thank you, and then take any questions. Thank you.
Thank you very much, Craig, for your patience and your capability to do it, and your kindness to collaborate with us. Craig, you have some couple of minutes, or you need to leave now?
I have to go in a couple of minutes to do some contact tracing.
Okay, so thank you very much. Please, Alan, Nick, you can open your cameras and your mics. Gracias, Diego. I think that in order to take this advantage of these 2 minutes from Craig, I would like to ask Craig about the contact tracing program. If you're in your program, you only call the people for take all the data, or you have other activities with them? I mean, you schedule appointment with the doctors, or you send the test to the house, or you need to collaborate with the police for doing mandatory in isolation, this kind of work, or it's just the taking the information about the contact? How many contacts usually each index cast has? Perdón, rápidamente, solamente preguntarle que le estoy preguntando qué otras actividades se hacen aparte de llamar por teléfono y pedir los datos, o como por ejemplo sacar los turnos o llamar a la policía si la gente no se quiere quedar en casa, y cuántos contactos hay por caso.
Okay, so it is done many different ways in different parts of the country, but in our unit we receive a laboratory notification 4 times per day. We get the reports from the laboratory. We immediately telephone the case and identify their contacts, and we would aim to have contacted all their contacts within 8 hours, and we would interview them and ensure they were in isolation the same day. And normally a young person may have 8 or 10 contacts. An older person may only have 3 or 4 contacts. An Aboriginal family member may have 30 contacts. So it really depends on the person.
Okay. This is my dog, sorry. Working from home. Entonces nos decía Craig que en las 8 horas que trabajan pueden evaluar aproximadamente 10 contactos de cada caso, y si el caso índice es un pueblo originario, personas de pueblo originario pueden llegar a necesitar hacer hasta 30 evaluaciones de contacto de cada caso índice. And so, Craig, do you think that what is happening now in Melbourne with so many cases every day, is the system is capable to manage? Le preguntaba si ahora con lo que está pasando en Melbourne, que aumentaron los casos en forma importante, si van a poder manejarlo, por ejemplo, con este sistema.
Well, I think, as the Victorian Chief Health Officer has said, that once it gets to a very high caseload and there's a delay in contacting the cases, so we cannot intervene adequately. We're not able to contact all the cases. We don't identify all the cases, and we can't get them into isolation, and we can't get their contacts into isolation early enough, then contact tracing cannot control. Contact tracing and isolation is not enough. It's too slow, and we need to rely on more broader public health containment efforts, such as lockdowns, to stop the cases so we can get them under control again.
So, lo que nos decía es que si no somos capaces de hacer la búsqueda de los casos y de los contactos rápidamente y en el momento, en el día, y poner esas personas que se han estado expuestas en aislamiento, entonces el programa no va a generar mucho beneficio y hay que recurrir a otras medidas de salud pública como las cuarentenas, los bloqueos, el aislamiento de toda la zona. So, Craig, thank you very much. You need to leave. We are very happy to have you here, and thank you for adapting to this change in the last minute. Thank you very much. I hope
Thank you very much. Good luck with the pandemic. Goodbye.
Thank you. Good luck to you also. So, nosotros vamos a poder seguir todavía unos minutos más para hacer algunas preguntas a Allen y a Nick. Y entonces, en primer lugar, déjenme comentarles que gracias a la Organización Panamericana de la Salud, era, digamos, encargado, asesor regional en hepatitis C, y entonces conoce mucho la región, y por suerte también como y para que nos comentes qué piensas tú de que podemos aprender nosotros o ustedes de Argentina, y nosotros de Australia, y cómo podríamos traer, digamos, o enmarcar en Latinoamérica los beneficios que ha mostrado el control del COVID en Australia.
Gracias y gracias por la oportunidad, Omar. Yo creo que tu micro no estaba funcionando perfectamente, pero sí, yo estaba trabajando con la OPS para 3 años hasta el principio de este año en Sudamérica. Y estoy trabajando como médico clínico aquí en Australia en este momento. Entonces, yo creo que fue una experiencia interesante para regresar, para ver lo que está pasando aquí en Australia y para pensar cuál sería apropiada en países de América Latina. Primero, un comentario sobre el app de flu tracking, porque yo creo que estos aplicativos, estas intervenciones son fáciles para implementar. El flu tracking es una aplicación, necesitamos internet, la capacidad para analizar los datos, más o menos es fácil para implementar. Y me parece estos tipos de intervenciones serían apropiadas, sería útil para implementar. Otra intervención, otra iniciativa en Australia que me parece es útil en este momento es que tenemos un sistema de la salud universal, es público más o menos, mezcla, pero lo que el gobierno hizo durante la pandemia en el principio fue para implementar un sistema de telemedicina y videomedicina. Entonces, es posible para ir a tu médico virtualmente con un video conferencia o una teleconferencia, y el sistema paga para esta consultación, exactamente como si fue en presencial. Entonces, eso es muy importante, obviamente, para la seguridad de los profesionales de la salud en este momento con la pandemia, pero también es importante para comunidades rurales o remotas que no tienen acceso a servicios especialistas y todo eso. Yo creo que también lo que fue una buena cosa con respecto de la respuesta a COVID fue la coordinación de todos los estados y territorios en Australia. Entonces, cada territorio tiene su propio sistema de salud público y tiene un jefe, se llama Chief Health Officer, y el país también. Pero hay en este momento un grupo de todos estos Chief Health Officers y el Chief Health Officer del país juntos que están reuniendo todas las semanas. Entonces, la respuesta de salud pública está coordinado muy bien. Y esta información es como, el mensaje es lo mismo dentro de las profesionales y el sistema de salud pública para proveer consejo al gobierno del nivel de Estado y la nación. Entonces, la coordinación de la respuesta fue buena en este sentido. Finalmente, en temas generales, hay mucho más interés y en análisis económicamente con respecto de qué va a funcionar y qué podría ser o podría tener el impacto más fuerte en el sistema de salud. Para cuando el país está presentando una nueva intervención o medicamento, todo esto, hay un análisis económico para mostrar que este sería el impacto económicamente y este sería el retorno de inversión para el país de nivel nacional. Entonces, estas cosas me parece sería fácil para implementar y me parece son cosas que están muy importantes con respecto del sistema de salud en Australia.
Sí, gracias, Nick. Yo creo que ustedes han sido pioneros en Australia de la historia clínica electrónica y eso facilita mucho la telemedicina y eso es lo que les ha permitido pasar rápidamente a esa etapa, y creo que acá también el COVID ha de alguna manera en algunos lugares facilitado mucho de estos procesos, aunque evidentemente estamos mucho más atrás. No todos los sistemas, los privados han podido hacerlo más rápido y algunos distritos que otros por la falta de las historias clínicas electrónicas, claramente. Pero bueno, we have here to Allen. So Allen, I wanted to say thank you for your presentation, and also it's a point that I am very curious about what we should try to do with COVID. I mean, as a city, we should try to eradicate the disease, and how can we do this in big cities that has big hotspots and a lot of mobility? Only for reducing the burden in the health system like other countries propose, you know. Could you follow me?
Yes.
Déjame que traduzco, que le estoy preguntando si qué deberíamos hacer, porque acá está siempre la discusión si esto realmente vamos a poder eliminar el coronavirus de una sociedad o si lo que hay que más que no el sistema de salud un poco baja, ¿no? So go ahead.
Yeah, I think this is a conversation that we are having again in Australia. So the aim of the government aim has been, they say that we are aiming for suppression and not for elimination. But obviously it's hard to calibrate your public health interventions to get one, and sometimes unexpectedly it appears that many of the jurisdictions in Australia have achieved local elimination, as has New Zealand. The problem with eliminating is that everyone thinks they can go back to normal, and they can for a while until it is reintroduced, and then it takes off very quickly again. So I think it's difficult. At the moment, we can't really entertain that now because we have an outbreak and we need to get this under control. So this decision does not have to be made in the next month, but it is an ongoing question. I think in Argentina, your situation is a bit different. And I think having Brazil on your border would make it very difficult to eliminate. I think will always be the risk that it will be reintroduced by someone coming from the border. Your microphone's off, Omar.
¿Se me oye mejor? ¿Se oye bien o no? ¿Sí? Ok. Allen decía que, bueno, el esfuerzo de erradicar el virus, eliminar el virus, es solamente, perdón, en Nueva Zelanda. Se han intentado, digamos, y que es bastante complicado porque uno intenta hacerlo para volver a la normalidad, pero rápidamente puede haber un brote que nos hace tener que volver todo atrás, ¿no? Y entonces, en Argentina, con la situación que tenemos, sobre todo con la situación tan cercana de Brasil, sería mucho más difícil también. But Allen, we have a situation here in Buenos Aires with 90%, more than 90% of the cases from this city and other 30 cities close to Buenos Aires, the metropolitan area. 40% of the cases are with the unknown index case, a community case without a link to a positive case. So we are now in phase 1 again, but today the feeling of the people and the commitment of the people to the lockdown, the isolation measures is not so good as at the beginning because the people is tired, anxious, and so what is the prospect in this situation? What is, have you had something similar in Melbourne after so many months of epidemics or not?
Yes, I think we have the same issue. Actually, I'm just going to share my screen and I can show you some data. Are you able to let me share my screen, Diego? So I pulled out Apple and Google data. Oops.
Diego, ¿le podés dejar compartir pantalla?
Ya mismo.
Le estaba preguntando a Allen si,
estamos.
dándole que tenemos la situación en Buenos Aires con más de 90% de los casos de Argentina, con más de 3.000 personas y que 40% de casos comunitarios y que la gente estaba muy nerviosa con la fase 1 y que no estábamos cumpliendo por ahí muy bien la cuarentena, ¿no?
So on the screen, at the top is Apple mobility data. Bottom is Google mobility data. On the left is Melbourne. On the right is Buenos Aires. So you can actually see that your lockdown is about the same, probably even more severe than ours in Melbourne. So you can see that there was a very early decrease in activities there. and then over time, people started to get sick of it. And then just in the last week, it has been, a lockdown has been reimposed, so it's a bit early to tell how effective that is, but you can see there is a sign that people are changing their behavior again. But also, if you look at Argentine data, it looks actually quite similar, and you know, the amount that people are going out is probably similar to Australia. But I'll just make the point that you know, mobility is not the only measure of physical distancing, and there are also questionnaire data that are done by telephone, and they ask every week a group of people that are representative, how often do you come into prolonged contact with people, and all the time sometimes, and so on. So that may help. And I think that there is a big awareness that this second lockdown in Melbourne is going to have a very painful economic impact.
Nos comentaba él que estaba comparando sus datos de Google de movilidad y de Facebook de movilidad, y que comparado Australia con Argentina o Buenos Aires, digamos Melbourne con Buenos Aires, se nota que el lockdown ha sido como mucho más importante, que se nota cómo se ha ido relajando con el tiempo, que quizás en Australia se ha relajado incluso un poco más que acá, y que ellos tienen una situación ahora en Melbourne donde también poner una nueva que tiene la gente. But Alan, we have 3,000 cases every day. So even though we have a good reduction in the mobility, we have 3,000 new cases every day. So what else it should be suggested from the public health standpoint?
So, I mean, I guess the questions that would come through my mind is you know, I know that a lot of them are unknown, but, you know, what is the setting in which they are occurring? Is it in households? Is it in workplaces? Is it in a particular part of the city? Are there people that, you know, if there is a missing link in the transmission chain, is that because people are not being tested? And if they are not being tested, why are they not being tested, and so on? So I think they're probably if the whole lockdown working to control infection, there probably needs to be more done in what is the situation, what is the next thing that can be done to control this better, and I don't know that the answer to that.
Sí, lo que me decía Allen es que tendríamos que analizar mejor los datos en Argentina, a ver dónde es estos casos, dónde son estos contagios, si es en un barrio específico, en familias específicas, si son empleados o son brotes, y tratar de analizar eso, qué se puede hacer para acelerar ese diagnóstico, acelerar esos aislamientos en estos grupos. Allen, acá tengo otra pregunta de la doctora Roses, Mirta, que nos comenta, digamos, que tenemos mucho intercambio con Chile y Bolivia a través de la frontera y gente que se mueve internamente y externamente un montón. So here Mirta Roses is commenting about the lot of exchange with Chile and Bolivia through land borders, and a lot of cargo movements of people and cargo across the countries and also inside the countries. So this is a situation in Argentina we have, and actually many of the new cases in the provinces are people going out from Buenos Aires. No? The other question that the Dr. Rosa has, or the question that Dr. Rosa has, is if in Australia there are any social protection measure applies in terms of providing cash transfer for those unable to work, particular in those in daily wage.
Yeah. So yes, there are. Victoria has announced that for those that cannot get illness leave or any other sort of leave, that there is a cash transfer. It is, I think it's about $100 a day and the idea is that will should stop people not being tested because they cannot afford to not work. But that is clearly very expensive and difficult. And I think there are signs that it is, you know, you don't want people just saying, I want a test so I can get some money. So it's a difficult situation for the government. But there are some social.
Sí, hay algunas.
Also, we have the test is also free. So in Australia, people do not have to pay for healthcare or pathology.
Bueno, la salud es gratuita en Australia, pero el gobierno está facilitando $100 diarios a aquellas personas que tienen que estar en aislamiento, ¿no? En isolation. Okay.
And the border issue, Alan, and the border issue?
Oh, sorry, I didn't catch the question.
No, it was not a question. It was a comment. In Argentina, it's a problem. I don't know if it's a problem in Australia.
Yes, it is. And so Melbourne is exporting cases to other jurisdictions. We also have the issue, probably like Argentina, is that the border between particularly Victoria and New South Wales, which are very large states, have communities that live on both sides. So they might work on one side of the border and live on the other side of the border, or their hospital is on one side of the border and they live on the other side of the border. So trying to enforce that border is very difficult.
Nick, do you want to make a question?
Yeah, no, just a comment. Overseas travelers coming into Australia at the moment, they need to quarantine for 2 weeks. So las personas que están entrando al país en este momento tienen que cuarentenar para 2 semanas en hoteles en la ciudad donde están llegando. Y tienes que, la prueba para estas personas es mandatorio, es obligatorio.
Okay. Okay. And Alan, the contacts are, you use testing for the contact people and also for the criteria for discharge from the hospital. Is required to have 2 PCR or a move forward to directly clinical discharge?
Yeah. So for cases in the community, we do not require testing. So it is 10 days after the onset of the illness and 3 days after resolution of symptoms, no testing is required. For patients that have been in hospital, it has changed. It was that we required 2 PCRs to let them, and they were at home. The exception is that if they are still in hospital at 10 days, then we will require testing before they come out.
Okay, o sea, los criterios de alta son los mismos que para pacientes ambulatorios que tenemos nosotros, para pacientes leves, o sea, pacientes que están más de 10 días sin síntomas, más de 10 días del inicio del síntoma y 3 días sin síntomas, y no les piden PCR, y a los pacientes internados sí todavía les están pidiendo. Nick, I say well? ¿Dije bien?
Yeah, sí.
Exactly.
I have a question, Alan.
Sorry, just to add to that, the one situation that we are finding very difficult is if they are still in intensive care at 10 days, then whether they can come out of isolation or not. And we are requiring testing clearly in that situation, but we also require that they stay in isolation for longer.
Okay.
So, Alan, I have a question. So, in Victoria at the moment, in Melbourne, there are 150 to 250 cases being identified a day. Now, 2 weeks ago, that was 5 to 10 cases, or a lot less. If these cases increase, what is the process for deciding what the next intervention will be? How will that decision be taken? If, for example, we go now to 1,000 cases a day, how will the decision be made to implement the next phase, and what would be the next phase of intervention?
Sorry, Nick está preguntando que ahora que tienen 250 casos cada día, antes tenían 20 casos, ¿qué pasaría, digamos, cuándo habría que tomar nuevas decisiones y qué decisiones habría que tomar, por ejemplo, si siguen aumentando los casos y hubiera 1000 casos cada día? It's a very good question because this is the question that we should have replied 1 month ago when we were having 100 cases and now we have 2,000 or 3,000 every day. Digo que es una buena pregunta porque hace un mes nosotros teníamos 100 casos, 150 casos cada día y ahora estamos con este número muy alto, ¿no? Ale?
That's a really good question. I think there's probably two parts to that question, if I understand it correctly, that what is the process by which decisions are made, and then what is the actual intervention. So the process by which decisions are made is that in Australia, at least, the public health is a state responsibility. So the decision would be made at the state level. There is obviously internal committees within the Department of Public Health that will, feed technical advice up to the state cabinet. So that is the governor, the premier of Victoria, and then he will make the decision about what is to be done. There is also the national, because we're a federation, there is also the national committees. So that's the CDNA, the Communicable Diseases Network of Australia, the Australian Health Protection Principal Committee. And their job is really to try and support Victoria. So Craig, actually, he's from New South Wales and he's come to Victoria to help with the Victorian response. And there are actually many experts like Craig that have come to Victoria to help from other jurisdictions as well. And they are also helping provide analysis and reporting and contact tracing and everything as well.
Esa es la first part of the question, but give me a second. Bueno, dice como que la respuesta a lo que le había preguntado Nick tiene dos partes. Por un lado es cuál es el proceso para la toma de decisiones, y después la segunda parte es cuál es realmente la posible intervención que se puede proponer. Y entonces el proceso es un proceso similar a aquí, podríamos decir. Tienen un país federal, entonces la decisión está en la responsabilidad del instituto que vigila la salud pública en Victoria, y eso hay un gabinete, un consejo, digamos, asesor también, y la responsabilidad también influye hacia el nivel nacional. Y que una de las cosas, una de las ventajas que podríamos también por ahí prestar atención nosotros es que lo que sí están viendo en Victoria es que hay mucha gente de otros lugares que viene a colaborar, digamos, porque en Australia ahora la situación está focalizada en Melbourne, en Victoria. Entonces gente de salud pública de otros distritos donde la situación está tranquila está viniendo a ayudar a llevar adelante esa intervención ahí en Victoria. And the second part of the question, Ale?
Yeah, so what it would be done would be difficult, I think. As the data suggests, that we didn't have, our lockdown was probably not complete. I think that if it got out of control, there is still one more stage that can be invoked, and that would be, the shelter in place. You cannot leave home at all, but there would not be a lot of appetite to do this. I think as I answered before, I think there probably needs to be a bit more exploration of where the transmissions were occurring. So are they occurring in households? Are they occurring in workplaces? Are they young people, old people? Are they events that are not meant to be happening, or are they occurring in populations that are missing the message? And that would be I think the key to the next stage. I think also that we have imposed what's called a hard lockdown, where the police enforce it very strictly. We haven't done that to a large extent, and it would obviously be very difficult, and again, not very, there wouldn't be a lot of support from the public, I suspect. But again, that is also an option. So I think it is about weighing up all the different options to try and target the intervention as best that you can to the epidemiology. And then bearing in mind, it does take a little while to work. So if there were 1,000 cases next week, it would not be good, but I wouldn't automatically say that that was a sign of failure.
Ok, lo que dice que en este momento en Australia, en Victoria, hay un cierre, un lockdown, pero que no es tan agresivo como podría haber sido o como era, que había sido antes. Entonces todavía podría pensarse en profundizar un poco más esa cuarentena. Incluso también se podría pensar quizás en otras cuarentenas como más con intervención policial, aunque no sería algo deseable porque el público no estaría de acuerdo y generaría reacción negativa. Entonces quizás es mejor focalizarse en dónde está ocurriendo la transmisión y ser como mucho más orientado hacia si la transmisión ocurre en niños, en grandes, en barrios, en grupos específicos, y llegar con un mensaje más claro a esos lugares e intervenciones más dirigidas. Sansin, Nick, si me pierdo de algo, por favor. ¿Sabe? No, Ale, acá tenemos digamos, acá de hecho fue la epidemia en Argentina fue probablemente la primera epidemia importante, grande, en grupos vulnerables. Porque nosotros vimos la epidemia venir desde los países ricos y no se prestaba mucha atención a barrios pobres o a barrios o a pueblos originarios, y eso es lo que tuvimos en Chaco y en Buenos Aires, y a partir de ahí la dificultad y la explosión y la dificultad de poder controlar. Y el gobierno mismo implementó un mecanismo que se llama plan detectar, que es la búsqueda de las personas sintomáticas casa por casa con el diagnóstico inmediato casa por casa en estos barrios específicos que al menos están mostrando buenos resultados. Entonces quería preguntarte si hacen algo similar. So in Argentina, we have the first probably experience in having COVID, a large amount of COVID through the vulnerable people and vulnerable neighborhood. We couldn't see this in Europe or in China when the epidemic started. So we had to develop the program when we realized that the number of cases in slums were being a lot. So we put in place a system that is, or the National Ministry of Health put up a system that is called Detectar, that go house door to door, trying to locate symptomatic people to be tested in the moment. And I wanted to ask if you have something similar there. And probably only to share the experience, the only difficulty was to try to really expand the program and coordinate with the local governments, because this is a national program. I don't know if you have something similar.
Yes, actually, we have almost exactly the same situation. So we have what's called public housing. So housing that is provided by the government to relatively poor people. Many of these people are immigrants and do not speak English, and it's hard to communicate with them, and have a lot of social issues in some of these places. So there were 9 towers of about 3,000 people where there was quite a lot of infection. I think we're up to 60 or 70 cases or something at the moment in those areas. And this was an area that the police moved in to lock them down. And I think that it is difficult when the police are involved. It makes it look like it is punitive. But they've been trying to, make sure that there are lots of health workers and social workers and other people to support them and to make sure that they're all fed. So I think it is important that it doesn't look like a police operation, that it's, the government trying to support them rather than to detain them. I think this is similar to actually other countries have had this issue. So Singapore have had this issue in their foreign workers. They live in dormitories, and they had about, I think, about 400,000 people in some of these areas. And they, again, also went door to door. I think in those sort of situations, it often helps to actually test all the people, whether they're symptomatic or not symptomatic, because the infection is so high. If that is possible to do with the laboratory capacity, that's one I think lesson that we have learned from that. But I think it is important that, especially where if there are slums and there are people that are marginalized, that it doesn't look like that you're putting them in a prison.
Bueno, comentaba que sí, que han tenido ese problema, que obviamente hay grupos de gente que tiene muchas vulnerabilidades también en Australia, sobre todo inmigrantes, y que han tenido, digamos, estas discusiones de si involucrar o no a la policía en la búsqueda o en la ayuda, porque tienen la percepción de que la policía los va a ir a perseguir y no a ayudar. Entonces es complejo y viven más o menos las mismas problemáticas que aquí. Lo que quizá ellos van puerta a puerta también es algún sistema que también se vio en Singapur, que también presentó digamos, estos brotes en barrios de hasta 40.000 personas, como tenemos acá en Buenos Aires también, y que lo que decidieron o que eventualmente hacen es hacer el testeo no solamente a los sintomáticos, también a los asintomáticos, porque a la gente sin síntomas, porque es tan alta la transmisión a veces en estos lugares que prefieren hacer las pruebas a todos. Nick, do you want to comment?
Sí, no, solo para comentar un poco sobre, porque el Chaco, por ejemplo, porque aquí en Australia tenemos mucha gente que están indígenas, que están muy vulnerables por causa de condiciones crónicas, enfermedades crónicas, etcétera. Y lo que pasó en todos los estados, en estas comunidades rurales, estos estaban cerrados completamente. No fue posible para ir. Tiene que tener una aprobación que si estás trabajando, estás un trabajador esencial para ir a estas comunidades para protegerlos. Y en este momento no tenemos casos en estas comunidades indígenas vulnerables. Entonces está saliendo bien. Y con respecto del mensaje, porque esta cosa de la corona es sobre cuál es tu mensaje, es una cosa sobre la calidad de la comunicación. Dos cosas. Una es que en Australia los mensajes que salieron fue...
What? Se cortó. Oh. Okay. I don't know what is the message. Su gusto se cortó cuando nos iba a decir el mensaje de Australia. Okay. I will continue with Alan. Alan, Dr. Roses asked if in Australia, are you monitoring the other virus, if the influenza really, as Craig showed in the flu tracking and the results from the symptoms, the self-reported symptoms, but if you know the reduction in the surveillance system in influenza or other respiratory virus.
Yes, actually all our influenza surveillance systems are collecting both influenza and COVID data, and we know that there is very little influenza out there. There is a little bit of rhinovirus emerging, but I think, I think there's two important things there. So influenza and rhinovirus and probably RSV are probably more diseases of children, and having our schools open will probably result in some of those viruses coming back, but hopefully not COVID, which doesn't seem to be transmitted through children. The other very important piece of information from flu tracking actually is that they ask them, if you have an illness, did you get tested? And actually that's a very important metric for us to say that are people still coming forward for testing? And, you know, they are not, flu tracking participants are not normal, you know, not like normal people, but, you know, where that changes is where we would be encouraged or start to worry that there is illness out there that we are not, that we're not detecting.
Thank you. Ahora te devuelvo, Nick, déjame que le traduzco y te devuelvo para que nos digas realmente la comunicación de Australia. Pero lo que preguntaba la doctora Rose es si estaban haciendo monitoreo de influenza, y porque Flu Tracking mostraba que el self-report, que el autorreporte había bajado los síntomas, pero y me dicen sí, claramente ha disminuido los casos de influenza, hay un poco de movimiento de rinovirus y tienen, digamos, la sospecha de que eso va a aumentar con las escuelas, digamos, con los niños, con la transmisión entre los niños, y que no solamente tienen esa información, sino que además no es que es subregistro, sino que realmente ha bajado porque el flu tracking evalúa, no solamente pregunta si tiene síntomas o no, sino también si se ha hecho las pruebas, y entonces ahí pueden ver que realmente se están haciendo las pruebas, pero que la influencia da menos. Gracias por la respuesta, dice la doctora Rodríguez.
Sí.
Y que estaba diciendo que ha sido lo importante de la comunicación y se cortó la comunicación.
Sí, qué irónica. No, la cosa es que el mensaje viene en Australia del Chief Medical Officer, de los médicos.
Del ministro de Salud,
entonces,
del médico.
Sí, él es un médico. No es...
He only gets cut off with this important point.
De la salud es el... Sí. Pero no, el ministro de salud es el Chief Health Officer, Chief Medical Officer. Entonces, es una persona técnica. Dice que esta es nuestra recomendación. Y obviamente las políticas, los politicians tienen que implementarlo, pero el mensaje no es político, no es posible para descodar con este mensaje. Ese es muy importante, porque cuando en los países que tienen la corona, el COVID, como una cosa política, es más difícil para implementar lo que necesitamos hacer. Entonces, hasta ahora, yo creo que en Australia los mensajes están viniendo de las personas técnicas, los grupos técnicos. Entonces, tienen que más poder. Y otra cosa es que en estas comunidades vulnerables, parece que una cosa que no fue muy buena fue que la comunicación no fue directamente con estas comunidades vulnerables. Entonces, obviamente, los mensajes no llegaron a estas comunidades. Entonces, es muy importante para adaptar los mensajes y como engage con las comunidades en el como ground zero, en presencial.
Sí, es lo mismo que estamos viendo aquí, también la necesidad de trabajar en los barrios vulnerables con las organizaciones locales y con los representantes y los líderes barriales para poder llegar mejor, porque no son los mismos canales de comunicación los que se usan, no son, digamos, los avisos en internet o en la televisión, sino son más otros canales más informales. Bueno, I think that we should close here. Muchísimas gracias. I don't know if you want to make some one. Pero muchas gracias, Allen, muchas gracias, Nick, and I hope that we can continue working in the future with the Sociedad Argentina de Infectología and the Australian ID Society. Muchísimas gracias, te doy la palabra y después Nick puede cerrar. Alain.
Thank you. Thanks for the opportunity to talk today. It's very interesting to compare our notes and experiences.
Okay.
No, sí, muchísimas gracias por la oportunidad cuando estaba trabajando en Sudamérica y también con Argentina el año pasado, en julio. Y fue muy buena. Yo creo que hay oportunidades para colaborar. Nuestros países son parecidos, más o menos, en algún sentido, más parecidos que los países de Norteamérica. Entonces, es un placer para conectar. Estamos aquí, obviamente, estamos juntos en esta lucha, que es súper difícil de cualquier perspectiva. Entonces, muchísimas gracias y seguimos.
Sobrevivimos los problemas técnicos. Dieguito, cierra nomás. Muchas gracias.
Sí.
Gracias, Allen, gracias, Nick, por el esfuerzo, por su tiempo y por la delicadeza de hablar en nuestro idioma, que para nuestros espectadores los convierte a ustedes en gente cercana. Y eso es muy importante también para curar, estar cerca del otro. Gracias, Omar. Gracias a los que nos estuvieron viendo. Será hasta el próximo encuentro. Buenas tardes aquí.
Excelente.
Buenos días allá en
Gracias.
Australia.
De nada. Buenas tardes.
Gracias. Gracias.